I'm Dr. Samantha Hill, President of the Ontario Medical Association. Thank you so much for having me here today. We are all adjusting to a new normal, one that just 6 months ago was inconceivable. Normally, when a disaster like a hurricane or a tornado or a snowstorm is forecast, we go inside. We button up, we hunker down, and we wait for it to blow past. And then we come out and we clean up the mess. When we saw COVID coming, we did that. We buttoned up, we hunkered down, but it never fully blew past. And while we're now out and cleaning up the mess, we're realizing that we have to clean up with care. Because of the measures we must continue to take until a COVID vaccine or effective treatment is found, everything is slower. Everything takes longer, and capacity must be reduced. We have the demand. We simply can't fully switch on the supply. This is true in every aspect of our society, in retail stores, in houses of worship, on public transit, at restaurants, and in healthcare. So today, I'd like to share with you the new normal in healthcare from the OMA's perspective. While Ontario has been reopening, doctors were never closed. Throughout the pandemic, we continue to care for patients, although in dramatically different ways in reduced numbers. Mainly, this was done through virtual care, but also physicians working on the front line in hospitals, community physicians seeing patients in person who just couldn't wait to be seen. The pause on non-emergency care was absolutely the right decision. However, as we emerge from the first wave of COVID, the data is clearly showing how far behind we are now in seeing and treating our patients, and how long the road ahead will be. Pre-COVID, Ontario's 31,500 doctors would see 340,000 patients in a day. However, from March to the end of June, 11.5 million fewer patients saw their doctor than this time last year. And 2/3 of the missed visits were in physician-run community medical clinics, family doctors, specialists, diagnostic clinics. Because physicians often provide multiple services during a visit, the number of missed services is even larger. 3.7 million fewer services provided by primary care doctors, 2.5 million fewer services provided by specialists, 5.2 million fewer diagnostic services such as mammograms, colonoscopies, ultrasounds, CT scans, MRIs, and even cardiac tests. 1.2 million fewer procedures and surgeries, all of which are medically necessary. Without virtual care, the number of primary care and specialty care services would have been even fewer. Virtual care was a literal lifesaver when it came to patient care, and it will continue to be. When it comes to patient care, Ontario is firmly in the 21st century. However, the pace of progress in the administration of healthcare has been glacial, and we're pretty much stuck in the 1970s. Before COVID-19, doctors and patients relied on OTN, Ontario Telemedicine Network, for virtual visits, and most patients accessing OTN were from rural or northern areas. Until 2014, patients usually had to visit a local site like a hospital to access the technology. And although now they can access OTN on their computers or mobile devices, platforms like Zoom and FaceTime weren't even on the radar, and there wasn't a no-hit fee code your doctor could use for half a phone call with your patient. OTN has now migrated away from the on-site model to a place where patients can access technology from their home. When COVID-19 struck, OTN, and thus virtual care, was not universally available to all physicians and patients. The OMA lobbied the government for temporary OHIP telephone and video codes so all patients would have equal access. This was also necessary because OTN requires the patient to have a computer and internet access, which is problematic for economically disadvantaged patients, as well as those who live in rural or northern parts of the province where there simply is no reliable internet service. The government heard us and acted quickly, and March 14th, they introduced new codes. Given the success of these virtual codes through the first phase of COVID-19, OMA and the government have agreed to an extension of the virtual codes until March 14th, 2021. Ultimately, the OMA's goal is to have this made a permanent solution. Regardless of how great virtual care is, many patients must still be seen in person for diagnosis or treatment, whether that's for an injection or a diagnostic test, a physical exam, or a procedure or surgery, and post-operative care. However, like other public spaces, capacity will still be limited, and doctors will continue to see fewer patients each day. This is because of the time needed to clean exam rooms and equipment between patients, physicians changing PPE for each patient, and the physical distance protocols that must be in place in waiting rooms to keep the patient safe. There will also be fewer surgeries and procedures done every day for the same reason. I'm a cardiac surgeon, and there have been more than 1,000 cardiac surgeries missed. Where we could have done 2 or maybe 3 surgeries a day, we now often only do 1 or maybe 2. This is not because we're operating slower. It's because there are procedures in place where we need to don and doff PPE, where we need to wait for droplets to settle before having people come in or out of the room. Simple things like something is needed in the operating room that wasn't there before now requires a third person to go get it to reduce the risk of contamination. Even if operating rooms could run 24/7, there are still a limited number of surgeons, OR nurses, and all of the other staff available. Doctors already work an average of 52 hours a week, and in many cases, on call above and beyond that. It is simply not sustainable over the long term for doctors to work 100 hours a week. We have to ensure there are also sufficient beds available for recuperating patients. Just because I can do the procedure doesn't mean there's somewhere for that patient to recover. Unfortunately, until there's a widely accepted vaccine, herd immunity, or a significantly more effective therapy, doctors won't even be able to catch up on the backlog of care caused by COVID-19. We all know that there were long wait lists before COVID. We all know that hallway medicine was a norm before COVID. We all know that we fell behind during the first wave of COVID. And I'm here to tell you that we are going to continue to fall further behind, and those wait lists will continue to get longer. Longer wait lists mean patients have less access to preventative medicine, and patients with existing health conditions will have to wait even longer to see their doctors. When this happens, small health issues become bigger health issues. Big health issues become catastrophic. Patients who otherwise could have been treated earlier end up in the hospital or worse. That is what keeps me and other doctors up at night. The OMA has been working with the Ministry of Health to see how we can maximize the provision of healthcare, as well as to ensure that community healthcare infrastructure remains viable. We don't want to fall any further behind than we have to. What you might not realize about Ontario's publicly funded healthcare system is that there are 2 distinct parts, hospitals and community healthcare infrastructure. And that community healthcare infrastructure consists of several thousand medical facilities that exist outside of those hospitals. These facilities include family doctors' offices, which you're used to thinking about, but also specialist clinics and diagnostic facilities, and provide millions of services each month to patients. However, Whereas hospitals are funded directly by the Ministry of Health, community healthcare infrastructure is funded indirectly by the same taxpayer dollars through OHIP to the physicians who own and operate the clinics. This is done via the billings that the physicians generate. So even though community medical clinics are funded by taxpayer dollars, the doctors who run them are required to operate as small business owners. Now that's interesting because doctors were trained to be doctors. We were trained to care for patients. We never wanted to be small business owners, and we weren't trained to be small business owners. But we find ourselves operating businesses because that's just the way our healthcare system is set up. For the majority of physicians, about 55% of family physicians and virtually all community-based specialists, we operate under a fee-for-service model. That means that the only revenue generated is generated by billing OHIP a set amount for every medically necessary service we perform for a patient. This set amount is non-negotiable and it's defined. The average monthly cost for a community-based physician to operate his or her medical clinic is roughly the first 35% of those OHIP billings. These costs include clinic rent, salaries for nurses, receptionists, and other staff, medical supplies and equipment, personal protective equipment, electronic medical record systems, and more. For some specialties, these costs can rise to 50 or even 60% to cover the purchase of specialized diagnostic and treatment equipment and salaries for technologists. That's not a lot of room. When waiting rooms are full and there are long wait lists, the fee-for-service model isn't an issue. We can bill and we can generate enough to cover those costs. However, when the number of patients doesn't even bring in enough to cover expenses, like all small business owners, physicians go into their personal savings to keep those clinics afloat. During COVID, some physicians have seen up to a 70% reduction in the number of patients they've seen, even with virtual care. A growing number won't be able to stay open. The government COVID relief programs were created for average small businesses, and they don't take into account the nuances of how medical practices are set up, and many physicians aren't eligible for these supports. As these clinics become in greater and greater jeopardy and they start to close, that's another thing that keeps me up at night. The loss of even a piece of our crucial healthcare infrastructure will have a major impact on our ability to address the backlog, leading to even further increased wait times in hallway medicine. There are already 1 million Ontarians who don't have a family doctor. Every closure increases that number. We're already seeing closures start to happen. The OMA has never had as many inquiries from doctors about how to close down their practices as we have recently. At least 40 clinics across the practice have already closed down, and each clinic represents multiple doctors. It's very scary. Our healthcare system and economy are linked. We cannot have a strong economic recovery without a strong healthcare system. We cannot have a healthy population without a strong economic recovery. Physicians help create healthy communities, not only from personal health perspective, but also in terms of financial contributions. One report issued in June by the Conference Board of Canada for the Canadian Medical Association showed that physicians' offices and clinics contribute $14 billion a year to Ontario's economy and generate 125,000 direct and indirect jobs, representing about $7.2 billion in wages. The tax contribution is $5 billion a year, including $220 million in municipal taxes. Reopening the economy is important for Ontarians' financial, social, and developmental needs. At the same time, reopening is not an all or nothing scenario. We need a balanced approach that considers the risk of disease transmission in different settings to ensure a successful reopening that keeps safety a top priority. One of the most effective ways we can clamp down on COVID flare-ups and surges that are almost certain to happen is contact tracing. Contact tracing is the method by which public health officials track down people who have been in contact with confirmed cases of COVID-19, asking them to get tested and to self-isolate. Quickly detecting and isolating COVID cases through contact tracing is essential to safely reopening Ontario, limiting the spread of the virus and making sure we can stay open. The OMA and I encourage everyone to support contact tracing by keeping track of everyone you come in close contact with, either socially or in a public place. The new COVID Alert contact tracing app is now live, and as municipal leaders, you can be extraordinarily helpful in encouraging people in your communities to download it. The app is fast, secure, it's privacy protected, and it's a way to notify people who have been exposed to COVID-19. It uses Bluetooth, not Wi-Fi, to share anonymous, randomly generated codes with other app users nearby. If you test positive, you can anonymously notify others who have been near you in the last 14 days. And if you've been exposed to COVID-19 by another app user in the last 14 days, you will receive a notification. For those who can't or won't use an app, it's still important to track your contacts, and there's always low-tech paper and pencil methods. The OMA launched a special pocket journal where people can easily fill in their daily travels, and it's available in 21 different languages. You can find this on our website at oma.org, or you can visit the OMA's virtual booth for more information. Proactively tracking your contacts is much easier than retrospectively trying to remember where you've been for 14 days. In closing, I want to thank all of you for being frontline leaders in the fight against COVID-19. There's an old saying that all politics is local, and it turns out that that's never been more true than when dealing with a pandemic. We've all been pushed beyond expectations, yourself included, to keep your teams and your critical services going, including in some cases literally keeping the lights on. You've been integral in leading your communities through the first wave of COVID. And yet now you have to grapple with your own new normal, with the resulting burden on your local resources, your revenues, your services, and your people. The OMA stands ready to provide whatever help and advice we can, and our virtual door is always open. I must also give a shout out to my physician colleagues serving as medical officers and associate medical officers of health in your respective public health units for their truly extraordinary work and endless hours of service. Normally at this point in a presentation, I would open up for questions, but hey, it's a new normal. So the plan is that I will be at OMA's virtual booth from 1 to 3 today and on Wednesday morning, so please drop by. Our booth will be staffed throughout the conference with very knowledgeable folks, and we welcome the opportunity to meet with you and together to build a new, better normal. Thank you.